Assalamualaikum and a pleasant day to each and everyone. So, we are the group 2. We are going to report the fluid and electrolyte imbalance. So, what is fluid and electrolyte imbalance? It occurs when the level of the fluid and electrolyte in our body are either too high or too low from the normal. So, nabibase yung electrolyte levels depende sa what is electrolyte imbalance the patient have. So, now we are going to report the number 4 objective, 5 and 6. Number 4 objective is refer to the plan effective care of the patient with the following imbalances. Imbalances of the fluid volume deficit and fluid volume excess, sodium deficit and sodium excess, potassium deficit and potassium excess that is to be reported by Mr. Insail, Ms. Isahak, and Ms. Asula. The number 5 objective is to describe the cause, clinical manifestation, management, and nursing intervention for the following imbalances like calcium deficit, calcium excess, magnesium deficit, magnesium excess, phosphorus deficit, phosphorus excess, and chlorine deficit and chlorine excess to be reported by Ms. Aripin, Ms. Insail, Ms. Hiang, and Ms. Ismani. The last objective we are tasked to report is to explain the role of the lungs and kidney and the chemical buffers in maintaining acid-base balance. That is to be reported by Ms. Hassan and Mr. Hapas.
So good morning ma'am, I'm Al-Nasib Boranis Misail. So today I'm going to tackle the planned effective care of patient with the following imbalances, fluid volume deficit and fluid volume excess. So hypovolemia, FVD means fluid volume electrolytes, or hypovolemia occurs when loss of ECF stands for extracellular fluid volume exceed the intake of fluid. So causes of FVD or hypovolemia: abnormal fluid losses, vomiting, diarrhea, GI suctioning, and sweating. Next example is diarrhea. Then diarrhea treatment is drink plenty of liquid including water, broths, and juice. Avoid caffeine and alcohol. Add semi-solid and low fever foods gradually as your bowel movement return to normal. Try to cracker, toast, egg, rice, or chicken. Then, what are the clinical manifestation? Headache, fatigue, weakness, dizziness, or thirst. Then, nursing intervention. Monitor blood pressure, check vital sign, nothing, peripheral pulse, strictly monitor intake and output, observe the physical properties of the urine, give correct and right amount of fluid, provide frequent oral care. What is hypervolemia? A medical condition when you have too much fluid in your body. What is the causes? Heart failure, kidney failure, and cirrhosis or pregnancy. Then this is the picture of hypervolemia. Then heart failure. Nursing intervention. Weight in daily document changes is weight in response to therapy for edema. Frequent position changes in bed, elevate, feet, and sitting. And that's all.
Assalamualaikum. I'm Sarah Chisahak. Learning objective, plan effective care of patient with the sodium imbalance. My topic is sodium deficit or hyponatremia and sodium excess or hypernatremia. What is sodium deficit or hyponatremia? refers to a serum sodium level that is less than 135 MEq or 135 mmOI or L. Plan effective care of patient with hyponatremia. Closely monitor fluid INO and daily body weight. The nurse closely monitor fluid INO as well as daily body weight. Monitor laboratory values, example sodium, and be alert for GI manifestation, anorexia, nausea, vomiting, and abdominal cramp. Anorexia, loss of appetite. Be alert for nervous system change, lethargy, confusion, muscles twisting, and seizure. The nurse encourages food and fluid with high sodium. 9 high sodium fluid, packaged shrimp, vegetable juice, cottage cheese, ham, breakfast cereal, processed cheese, canned soap, butter, milk. The nurse encourages foods of fluid with high sodium content to control hyponatremia. For example, both contains 1 beef, 900 mg of sodium and 700 mg of sodium in 8 chua juice. Next, problem with water retention, restrict fluid intake. When administering fluid to patients with cardiovascular disease, the nurse assesses for signs of circulatory overload, example cough, dyspnea, puffed eyelids, dependent edema, excess weight gain in 24 hours. The lungs are auscultated for cracks. Next, when lithium toxicity observed to patient taking lithium, give supplemental salt and fluid. Supplemental salt and fluid are given when nurse observe for lithium toxicity to patient taking lithium. And the next, patient receiving isotonic or hypotonic enteral feeding avoided excess water supplement. Excess water supplements are avoided in patients receiving isotonic or hypotonic enteral feeding. Next, monitor serum sodium or patient at risk of hyponatremia. Next, what is sodium excess or hypernatremia? Serum sodium level higher than 145 MEq or 145 mmOI or L. The nurse provides oral fluid at regular intervals, particularly to patients unable to perceive or respond to thirst. It could be enteral feeding or parenteral route. Next, patient with diabetes insipidus, adequate water intake must be ensured. Next, patient with neurologic parenteral fluid replacement may be prescribed. Next, the nurse must monitor the patient response to the fluid by receiving serial serum sodium levels and by observing for change in neurologic signs.
Assalamualaikum and good afternoon, ma'am. I am Nadia M. Masula. So, my report today is all about the plan effective care of patient with the potassium imbalances. So, potassium imbalances, it is a major intracellular electrolyte. So, meron siyang two types, potassium deficit hypokalemia and potassium excess hyperkalemia. So, ibig sabihin no, meron siyang low potassium and high potassium. So, yung low potassium, ito yung potassium hypokalemia. Yung high potassium, ito naman yung potassium excess hyperkalemia. Okay. So, dito, what is potassium deficit o hypokalemia? It refers to serum K less than 3.5 mAqL. So, less than 3.5 lang yung fluid ng potassium ng hypokalemia. Kaya nga siyang tinawag na low potassium. And there are the symptoms na mafe-feel talaga nila. Ito yung weakness, yung mahina yung katawan, fatigue, muscle cramp, digestive problems, muscle aches, tingling and numbness, breathing difficulties, and mood changes. So ito yung mga symptoms na mararanasan talaga ng isang patient kapag low yung potassium niya. So, dapat encouraging natin yung patient at least to eat food rich in potassium. So, mga banana, orange, fruits, ganyan. So, dapat din i-monitoring yung fluid input and output. So, dapat i-monitor din natin yung input, yung pag-intake natin ng fluid, yung input, at saka yung output, yung paglabas ng sa paglabas ng fluid. So dapat i-monitor din natin 'yon para malaman natin yung level. So, and then the next is monitoring the ECG. So dito, i-monitor yung ECG for changes. Check yung ultra blood gases, yung process ng fluid. So, the next one is the potassium. What is potassium excess or hyperkalemia? So, di ba guys, sinabi ko kanina yung potassium hyperkalemia, ito yung high potassium, yung mataas yung fluid niya. So, kapag mataas yung potassium mo, so it means the serum potassium level is greater than 5 mql. So, mataas talaga siya. So, ito yung mga symptoms na mafe-feel talaga ng patient kapag high yung potassium niya, mataas yung fluid niya, which is the abdominal pain, chest pain, heart pain, muscle weakness, and nausea. So, ito yung mga symptoms na ma-experience talaga ng patient kapag mataas yung fluid niya, high of potassium siya. Guys, so the next one, so ito yung mga potassium na kailangan i-avoided talaga ng patient kapag mataas yung potassium niya. So, kailangan niya hindi kumain ng vegetables, ng legumes, ng meat, ng milk, ng egg, and coffee. Kasi yung mga food na ito, guys, is nagbibigay sila yung nagbibigay weight, kaya tumataas yung potassium natin, yung fluid. So, kailangan i-avoid natin, guys, yung mga pagkain na ito. Okay? So, care is taken to monitor potassium solution closely. Pay ka talaga sa attention ng concentration solution at saka yung rate at administration. So, dapat dito, pay of attention ka talaga dito sa pag-administer ng potassium. And the next one is, the nurse must caution patient to use salt substitute sparingly if they are taking other supplement form of potassium. And then, dito din, so kapag nalalaman ng nurse na may other na supplements na tinitake ng patient, so kailangan hindi siya mag-use ng salt substitute. So, in addition daw, kapag may potassium conserving and potassium supplements and salt substitute, dapat hindi talaga ibigay sa patient with renal dysfunction. So, that's all. Thank you.
Assalamualaikum warahmatullahi ta'ala wa barakatuhu, and good day to everyone. My name is Maika S. Aripin, reporter number 5, reporting the number 5 objective, which is to describe the cause, clinical manifestation, management, and nursing intervention of calcium imbalances or hypocalcemia and hypercalcemia. What is hypocalcemia or calcium deficit? It is wherein the serum calcium value lower than 8.6 mg dl. What are the causes of hypocalcemia? Number 1 is hypoparathyroidism. It is wherein our body produces abnormally low level of parathyroid hormone. Next is, what is malabsorption? Malabsorption is an impaired absorption of nutrients. Next is pancreatitis. It is an inflammation of the pancreas. Next is alkalosis. It is an excessive alkaline or bases in the body. Next is vitamin D deficiency. Then, massive subcutaneous infection. Other causes is generalized peritonitis, the swelling or the redness of the lining of the intestine. Next is the massive transfusion of citrated blood, wherein the citrated solution combined with the iodized calcium that can temporarily remove from the circulation. Next is chronic diarrhea, which is the reoccur of the feces in the form of the liquid. Next is diuretic phase of the kidney injury. It's hard to keep the right electrolyte balance. Another causes is the increase of PO4, which is PO4 referred to the phosphate in blood. Next is burns, which is calcium wasting. Next is alcoholism, referred to the isotonic retention of the water. So, what are the clinical manifestation of the hypocalcemia? Number one is numbness, tingling of toes, fingers, and circummoral region. It is the patient also positive in Trousseau sign, which is the involuntary construction of the muscle, particularly in hand or wrist. Like for example, carpopedal spasm or bronchospasm. Next, also the patient is also positive in Vostick sign, the facial muscle twisted when you tap the cheek of the patient gently. So next, a clinical manifestation is hyperactive deep tendon reflexes, irritability, anxiety, impaired clotting time, decreases prothrombin, which is the plasma protein, diarrhea, decreased blood pressure. So, what are the management? Management in emergency pharmacologenic therapy, since the hypocalcemia is life-threatening and it need a prompt intervention. So, we need to use an IV administration of IV of the calcium salt as a treatment, and also the other route through parenteral route of calcium salt, for example, calcium gluconate and calcium chloride. So another management is the nutritional therapy. We need to administer the vitamin D, aluminum hydroxide or calcium acetate. We need to refer the patient taking the calcium supplements if the dietary intake is not enough to provide the body with the adequate calcium that needed by our body. Then we need to have the calcium containing like milk product, green leafy vegetables, canned salmon and sardines, and fresh oyster. So what are the nursing intervention we can do? So we need to monitor the airway status of the patient. We need to take the safety precautions. We need to educate the patient about the foods that is rich in calcium. Then we need to advise the patient to consider the calcium supplements, and we need to have the patient avoid the alcohol or caffeine, and we need to also have the patient to avoid the moderate cigarette smoking. We need to also avoid the patient to overuse of lactacid and antacid. My next topic in calcium imbalances is the hypercalcemia or calcium excess. So it is wherein the serum calcium value greater than 10.2 mg milliliter. So what are the causes? Number one is hyperparathyroidism. It is wherein the body produces high level of parathyroid hormone. And number two is malignant neoplastic disease, where the cell division that can be lead into a tumor, then prolonged immobilization, overuse of calcium, vitamin D excess, oliguric phase of urinal failure, wherein the patient can urinate only 400 milligram of urine every day, acidosis, which is the excessive acid in the body, corticosteroid therapy. The patient can have an osteoporosis or loss in bone taking this therapy. Next is thiazide diuretic use. The use of this medication to have a high blood pressure. Next is increased parathyroid hormone, and then the digoxin toxicity. So what are the clinical manifestation? Number one is the muscle weakness, constipation, anorexia, loss in appetite, nausea and vomiting, polyuria and polydyspnea, which is the excessive urination and excessive tears. Then hydration, hypoactive deep tendon reflexes, lethargy, which is the loss of energy or weakness of the body, deep bone pain, pathologic fracture, broken of the bone, then blank pain, which is happen at the back, calcium stone, hypertension. In management, we need to decrease the serum calcium level. So in return, it causes a hypercalcemia. So, number 2 is treating the underlying causes. For example, we need to use a chemotherapy to treat for the malignancy. And also, we need to use a partial parathyroidectomy for the hyperparathyroidism. So, what are the nursing intervention? So, we need to increase the mobility of the patient and encourage the patient to take the fluid 2.8 to 3.8 liter of water daily. And we need also to have the patient to take an adequate fiber in diet. And also, we need to monitor the cardiac rate and rhythm for any abnormalities. Next report will be fall into number 5 objective, which is to describe the cause, clinical manifestations, management, and nursing interventions of magnesium imbalances. So, magnesium imbalances or magnesium deficit or hypomagnesemia, and magnesium excess or hypermagnesemia. So, what is magnesium deficit or hypomagnesemia? It is referred to a below normal serum magnesium concentration, 1.3 mg per deciliter, and is frequently associated with the hypokalemia and hypocalcemia. So, what are the causes? Number 1 is gastrointestinal tract infections such as nasogastric sanction, diarrhea, or fistulas, because gastrointestinal tract has higher concentration in fluid from the upper tract. And also, another causes is alcoholism. So, for the patient who has a withdrawal alcohol, they need to monitor the serum magnesium for every 2 or 3 days. Next is other causes are the administration of aminoglycosides, cyclosporine, cisplatin, diuretics, digitalis, and amphotericin, as well as the rapid administration of the citrated blood. So, what are the clinical manifestations or the signs and symptoms that can be seen to the patient with this kind of electrolyte imbalances? Number 1 is neuromuscular irritability, Trousseau sign and Vostick sign, which is the involuntary construction of the muscle of the wrist and hands and the cheek of the patient. Next is insomnia, mood changes, vomiting, anorexia, increased tendon flexes, increase in BP. So, next is what are the medical management of these imbalances, electrolyte imbalances. Number 1, if the patient has a mild magnesium deficiency, diet can be prescribed with this to the patient. Like for example, taking the major source of the magnesium like green leafy vegetables, nuts, seeds, legumes, whole grains, seafoods, peanut butter, and the cocoa. So next medical management is the magnesium salt. We can, like for example, in the form of oxide or the gluconate. So the patient can prescribe with this kind of salt to replace the continuous losses. And then the patient also can receive a parenteral nutrition through the IV solution. Next is we need to monitor the output of the urine of the patient before, during, and after the magnesium administration. So, kailangan i-monitor to know the level of the serum magnesium in the patient body. So, next is we need also to monitor the vital signs of the patient. We need to assess frequently after the during the administration of the magnesium to detect any changes in cardiac rate or rhythm, hypotension, and respiration distress. Next is what are the nursing intervention. We need patient receiving digitalis are monitored closely because they are predisposed to digitalis toxicity if the patient is receiving a digitalis. And also the patient is education play a major role in treating magnesium deficit. Then, let's move on to magnesium excess or hypermagnesemia. It is wherein the serum magnesium level higher than 3.0 mg per deciliter. So, what are the causes? Number 1 is the kidney injury. Since the kidney excrete the magnesium, if the kidney injured, the kidney would be not able to excrete magnesium. Then next is untreated diabetic ketoacidosis, then adrenocortical insufficiency. Other causes are excessive use of magnesium-based antacid or lactacid and medication that decrease gastrointestinal motility. Then, what are the clinical manifestation, or what can we see to the patient with this kind, or what are the signs and symptoms that the patient manifested? Number 1 is the flushing. 2 is hypotension. 3 is muscle weakness. Then drowsiness, hypoactive reflexes, depression, respiration, cardiac arrest, and coma, and diaphoresis. Next is what are the medical management. To avoid the administration of magnesium to the patient, we must avoid the administration of magnesium to the patient with the kidney injury. And we need also to monitor the patient who is ill. Patient has a serious illness. We need to monitor them if they are receiving a magnesium salts. And we also need to all the parenteral and oral magnesium salt are taken by the patient. With the patient with the severe hypomagnesemia, we need to discontinue. What next is, we need to monitor the vital signs, noting the hypotensions and shallow respiration. Since these sign and symptoms can be seen to the patient with this kind of electrolyte imbalances. And also, medication that contains magnesium are not given to the patient. Also, with the patient who has experiencing kidney injury or compromised renal function. So, that's all. Thank you.
Assalamualaikum, I'm Sharhada Hyang. I am going to discuss about the one of the electrolyte imbalance, which is phosphorus imbalance. So in phosphorus imbalances, meron tayong tinatawag na phosphorus deficit and phosphorus excess. So when we say phosphorus, it is critical constituent to all body tissues, and it is essential to our muscles and red blood cells. So in our body, we should have take the phosphorus about 85% that's located in our bones and teeth, and 14% in our soft tissue, and less than 1% in the ECF. So the normal serum in our body is 2.5 to 4.5 milligram deciliter. So pag imbalance na yung phosphorus in our body, yun yung tinatawag na phosphorus deficit. So pag nag-increase naman siya is phosphorus excess. So next is, what is phosphorus deficit or hypophosphatemia? The hypophosphatemia, yan yung other tawag sa phosphorus deficit. So it means it is indicated by a value below of 2.5 milligram deciliter. So what is the cause? So it may occur during the administration of calories to patients with protein calorie malnutrition. So phosphorus deficit, although it is often indicate phosphorus deficiency, it is an abnormally low content of phosphorus in the lean tissue. It can be intracellular shift of potassium from serum into cells. So the next is the clinical manifestation or the signs of phosphorus deficit. So we have paraesthesis, muscle weakness, bone pain and tenderness, chest pain, and respiratory failure, seizure, tissue hypoxia, and nystagmus. Then for nursing intervention, so to prevent that phosphatemia, the goal in patient at risk for hypophosphatemia, it should be the serum phosphate level should be closely monitored and correction initiated. So when a patient is required the correction of the phosphorus losses, the nurse frequently monitors serum phosphate levels and document and report the signs of it. So pag malalaman na ng nurse na nagbaba na yung amount ng phosphate or yung rate ng phosphate in our body, kailangan i-report na to siya, and pag may mararamdaman na signs or symptoms para maagapan siya kaagad. So, pag yung patient naman is naka-experience na ng mild phosphate deficit, The nurse should encourage the patient to eat the foods like milk products, organ meats, nuts, fish, poultry, and whole grains. And pag nakaka-experience naman ng moderate na phosphorus deficit yung patient, the nurse should prescribe the supplement like Nutra-Pos capsules, K-Pos, and Fleet Phosphosoda. The next is, what is phosphorus excess or hyperphosphatemia? It is a serum phosphorus level that exceeds about 4.5 milligram deciliter. So what is the cause? The cause are acute kidney injury, excessive intake of phosphorus, vitamin D excess, respiratory and metabolic acidosis. Then, and also volume depletion, leukemia, and the last one is hypoparathyroidism. So what are the signs and symptoms? The signs are tetany, tachycardia, anorexia, nausea and vomiting, and muscle weakness. So what is the nursing intervention for it? So if a low phosphorus diet is prescribed, the patient is instructed to avoid phosphorus-rich foods such as hard cheeses, cream, nuts, whole grain cereals, dried fruits and vegetables, sweet breads, and food made of milk. So when a patient is under the phosphorus excess or hyperphosphatemia, the nurse should advise the patient or to avoid to eat the rich food such as yung mga hard cheeses, cream, nuts, whole grain cereals, dried fruits and vegetables, sweet breads, and foods that are made of milk. So, and also the patient should instructed to avoid phosphate containing laxatives and enemas. So that's all. Thank you.
Assalamualaikum and good morning. My name is Mr. Mrs. Mani, and for today's video, I'm going to explain about the chloride imbalances, which is and hypochloremia is an electrolyte imbalance that occurs when there's a low amount of chloride in our body. Chloride is an electrolyte. It functions with other electrolyte in our system, such as sodium and potassium, to regulate the amount of fluid and the pH balance in our body. So let's move on to our next topic. So we have here the chlorine deficit or hyperchloremia. So the cause is we have the GI tube drainage, which is a drainage tube that is bad into our stomach to drain stomach juices and fluids. Next is gastric suctioning, which is a procedure to empty the contents of our stomach. Next is gastric surgery, which is that helps you lose weight by changing how your stomach and small intestine handle the food we eat. And then next is severe vomiting, sumusakusuka, and then diarrhea, tumatay-tay. So next is administration of chloride deficit. So we have the low sodium intake, which is a low sodium diet limits high sodium foods and beverages. And the next is disease urine sodium levels, which is in hyponatremia. The level of sodium in blood is too low. Next is the metabolic alkalosis, which is metabolic alkalosis is defined as elevation of the body's pH above 7.45. And the next is the massive blood transfusion. Massive blood transfusion is traditionally defined as transfusion to 10 units packed red blood cells, which is or PRB uh, PRB PRBCs. So next is diuretic therapy, burns, yung nasusunog yung skin, yung body, padaran, and then fever or lagnat, and then IV or intravenous solutions. So next is a clinical manifestation, the signs and symptoms of hypochloremia. So we have the agitation or a state of anxiety or nervous excitement, and then irritability or which is irritability as a feeling of agitation, and then tremors, which is an involuntary rhythmic muscle contraction leading to shaking movements in one or more parts of our body. And then muscle cramps, which is a sudden and involuntary contraction of one or more of our muscles. Next is hyperactive deep tendon reflexes of our deep tendon. Next is hypertonicity. Hypertonicity is a muscle tightness or increased one, and which makes moving body parts more difficult. Next, we have tetany, which is the condition that causes involuntary muscle contraction and changes in our brain cells. And then, slow, shallow respiration, seizures, dysrhythmia, coma, and metabolic alkalosis. So let's move on to management. With the medical management, treatment involves correcting the cause of hypochloremia and contributing electrolyte and acid-base imbalances. And then ammonium chloride and acidifying IV or intravenous. And nursing management, the nurse monitor the patient's INO and then arterial blood gas values and serum electrolyte levels. And then we're going to monitor the vital signs, the respiratory assessment, educate the patients about the foods in high chloride contents. So when we're going to give the patient's food, it must be hefty, high in chloride contents. Next is in nursing intervention. In nursing intervention and mild cases, replenishing the chloride in our body can treat hypochloremia. This can accomplish either by consuming more salt or through receiving IV fluid. So let's move on to chloride excess or hyperchloremia. Yung kanina hypochloremia at ngayon hyperchloremia. So the cause is high serum chloride levels, lactated ranger's lotion, loss of bicarbonate ions, head trauma, increased respirations, increased excess adrenocortical hormone production. So, and clinical manifestation, the signs and symptoms of hyperchloremia are the same as those of metabolic acidosis, which is hypervolemia, hypernatremia, tachypnea, weakness, lethargy, and then deep and rapid respirations, diminished cognitive ability, hypertension. So, if untreated, hyperchloremia can lead to disease, cardiac output, dysrhythmias, and coma. So let's move on to management. Medical management, correcting the underlying cause of hyperchloremia and restoring electrolyte fluid and acid-base balance are essential. Nursing management is monitoring vital signs, arterial blood gas values. And INO is important to assess the patient's status and effectiveness of the treatment. Next, the nurse educates the patient about the diet. Next is nursing interventions. Next is nursing interventions, taking medications to prevent nausea, vomiting, or diarrhea. And then next, changing drugs if they are a factor in the electrolyte imbalance, drinking 2 to 3 quarts of fluid every day, and then receiving intravenous fluids, eating a better or more balanced diet.
Assalamualaikum. My name is Marceline A. Hassan. I'm the next reporter. So I'm going to explain the learning objective, explaining the role of the lungs, kidney, and mechanical vapor and maintaining acid-base balance. So acid-base disturbance are commonly in clinical practice, especially in critical care units, and identification of the specific acid-base imbalance is important in ascertaining the underlying cause of the disorder and determining appropriate treatment. So, acid-base balance is the lever of the acidic and base balance in your blood at which your body functions. The human body is to naturally maintaining a healthy balance of acidity and alkalinity. And plasma pH is an indicator of hydrogen ions H plus consideration and measure acidity or alkalinity of the blood. So normal range 7.35 to 7.45. This mechanism consists of buffer system in kidney and the lungs. So plasma pH is defined as a log H plus when H plus is increased, the pH decrease, the condition high of high plasma pH is called alkalosis. So low plasma pH as acidosis, the body has their lines of decrease against. And from the normal plasma pH, the chemical buffer the respiratory system. And buffer system is bicarbonate carbonic acid buffer system, which is assessed when arterial blood acids are measured. So buffer system is prevent major change and the pH of body fluids by removing of release H plus. They can act quietly no prevent an excessive change in the H plus concentration. And 20 part of bicarbonate HCO3 to 1 part of carbonic acid and H2CO3. If this ratio the pH will change is the ratio of HCO3 to H2CO3 that is important in maintaining pH, not absolute value. And CO2 is potential acid which dissolve in water. If they become carbonic acid, CO2 plus H20 and equal H2CO3. Therefore, when the CO2 is increased, the carbonic acid content is increased, the vice versa. If either bicarbonate or carbonic acid is increased or decreased so that the 20:1 ratio is no longer maintained, acid-base imbalance resort. The kidney regulate the bicarbonate liver and the ECF. They can regenerate bicarbonate ions as well as resolved from the renal tubular. So the kidney is the filter waste material out of the blood and pass them out of the body as a urine. And respiratory acidosis. In the most cases of metabolic acidosis, the kidney increase the hydrogen ions to help to restore balance. So in respiratory acidosis condition, the occur when the lungs cannot remove all of the carbon dioxide. The body procedure this cause of the fluid, especially the blood, to become too acidotic. The last is the lungs. Lungs, under the control of the medulla, control CO2 and thus the carbonic acid content of the EFC. So the lungs is a vital part of the respiratory system, which is allow you to breathe, and addition to the lungs, including the airway that carry air and out of your lungs. So that's all for the role of the lungs, kidney, and chemical buffer and maintaining acid base balance. And thank you.
Good morning, ma'am. I am AL-FAIZAL Esapat. Today, I would like to explain the rules of the lungs, kidney, and chemical buffers in maintaining acid-base balance. When we say the rules of the kidney in maintaining acid-base balance, they reabsorb the bicarbonate from urine and they excrete the hydrogen ion into urine. When we say the cell reabsorb the bicarbonate hydrogen CO3 from the urine back to the blood, and they secrete the hydrogen ion into the urine. By adjusting the amount of reabsorbed and secrete, they balance the bloodstream pH. Okay? The kidney help the lungs to maintain acid-base balance by excreting acid base into the blood. Look the picture. This is one example of the kidney rules and how to maintain the acid-base balance in the urine, back to the blood, and blood back to the urine. And acid-base balance is very important in living things because most enzymes can do their job only at a certain level of acidity, and cell secrete acid base to maintain the proper pH for enzyme to work. For example, every time you digest food, acid and base balance are worked in your digestive system. Okay? Next, there are mechanism by which the kidney and excrete the acidity and base urine follow. There are three. First, the large number of hydrogen CO3 are filtered continuously into the tuberculosis, and if they are excreted into the urine, this removes the base from the blood. Next, the large number of hydrogen ions are also secreted into the tuberculous lumens by the tubercular epithelial cells, thus removing acid from the blood. If more hydrogen ion is secreted than hydrogen CO3 filtered, there will be a net loss of acid from the cellular fluid. Conversely, if more hydrogen CO3 is filtered than hydrogen ion is secreted, there will be a net loss of base. Okay, watch this video for the acid-base balance.
pH is an indicator of acidity. The body's blood pH is strictly regulated within a narrow range between 7.35 and 7.45. This is because even a minor change in acidity may have devastating effects on protein stability and biochemical processes. Normal cellular metabolism constantly produces and excretes carbon dioxide into the blood. Carbon dioxide combines with water to make carbonic acid, which dissociates into hydrogen ions and bicarbonate. This is an equilibrium, meaning all of the components of the left and right sides coexist at all times, and the concentration of any component is determined by that of others at any given moment. The rule of thumb is an increase in concentration of any component on one side will shift the equation to the other side, leading to increased concentrations of all components on that side, and vice versa. This equilibrium is central to understand acid-base regulation. Continued carbon dioxide production by all cells of the body drives the equilibrium to the right to generate more hydrogen ions. Because pH is basically a function of hydrogen ion concentration, more hydrogen means higher acidity and lower pH. Normal metabolism therefore constantly makes the blood more acidic. The body must react to keep the blood pH within the normal limits. This is achieved by two mechanisms. Elimination of carbon dioxide through exhalation. The amount of carbon dioxide exhaled by the lungs is regulated in response to changes in acidity. A decrease in pH is sensed by central or arterial chemoreceptors and leads to deeper, faster breathing. More carbon dioxide is exhaled, less hydrogen is made, blood acidity decreases, and blood pH returns to normal. Pulmonary regulation is fast, usually effective within minutes to hours. Excretion of hydrogen ions and reabsorption of bicarbonate through the kidneys. The kidneys control blood pH by adjusting the amount of excreted acids and reabsorbed bicarbonate. Renal regulation is slower. It usually takes days to respond to pH disturbances. Although all of the plasma bicarbonate is filtered in the glomerulus during the first step of urine formation, virtually all of it is reabsorbed back into the blood. Most of this reabsorption happens in the proximal tubule. The amount of reabsorbed bicarbonate in the proximal tubule is regulated via a number of mechanisms in response to changes in blood pH. It increases during acid loads and decreases during alkali loads. While the proximal tubule basically returns filtered bicarbonate back to the blood, the downstream collecting duct generates new bicarbonate by actively secreting acids. As protons are depleted from the distal tubular cells, the equation shifts to the right, producing more bicarbonate, which then exits into the blood. Hydrogen ions secreted into the lumen combine with urinary buffers, mainly filtered phosphate and ammonia, to be excreted in urine. The ammonia buffering system is particularly important because, unlike phosphate, which is filtered in fixed amounts from the plasma and can be depleted during high acid loads, ammonia production is regulated in response to changes in acidity, and its concentration may increase several-fold when necessary. Blood pH is the main regulator of acid excretion, but potassium, chloride concentrations, and several hormones also play important roles. Pathologic changes may cause acid-base disturbances. Acidosis refers to a process that causes increased acidity, while alkalosis refers to one that causes increased alkalinity. It's not uncommon for a patient to have several processes going on at once, some of them in opposite directions. The resulting plasma pH may be normal, too acidic, called acidemia, or too basic, called alkalemia. Acidosis may result from inadequate function of the lungs, which causes arterial carbon dioxide to accumulate. This is respiratory acidosis. On the other hand, metabolic acidosis may result from excessive production of metabolic acids, ingestion of acids, decreased ability of the kidneys to excrete acids, or loss of alkali. Metabolic acidosis is characterized by primary decrease in plasma bicarbonate. Alkalosis can also be either respiratory or metabolic. Respiratory alkalosis is caused by increased ventilation, resulting in excessive exhalation of carbon dioxide. Metabolic alkalosis can result from excess loss of acids through the kidneys or gastrointestinal tract, bicarbonate retention, or ingestion of alkali. Metabolic alkalosis is characterized by primary increase in plasma bicarbonate. Thank you for watching. Please feel free to suggest a topic you want us to cover by leaving a comment below.
Okay, we're done watching the videos. Okay, let's proceed to the rules of the chemical buffer and the maintaining acid-base balance. When we say buffer, are solutions that contain the weak acid and its conjugate base, as such, they can absorb excess hydrogen ions or oxygen, hydrogen ion, and thereby maintaining overall steady by pH in the solution. Look the picture. This is one example of the chemical buffers. So when we say chemical buffers, ay ang mga solusyon na nagdalaman ng mahina at acid ng isang conjugate base tulad nito. Maaari silang sumisip sa labis ng mga hydrogen ion or oxygen. Dahil doon, mapamatili nila ang isang pangkalahatang matatag na pH and solution. The most important pH buffer
system is the blood involved the carbonic acid and a weak acid formed from the carbon dioxide, dissolved in the blood and bicarbonate ion corresponding the base. Okay? That's all. Thank you.
我总是轻描淡写告诉你。